The broadcast is now starting. All attendees are in listen-only mode.
Okay. Welcome, everybody. We're going to get started. My name is Roni Falk. I'm the Manager of Adult Day Services here at Leading Age Minnesota, and I'm so pleased to welcome our presenters here today for our Adult Day Services webinar on completing the needs assessment, social history, and individual service planning. So with us here today are Jill Slykew, the Unit Manager for the HCBS Licensing Division at DHS, and Cheryl Shanks, the Director of the Camilla Club Adult Day Program in Coon Rapids. Jill is here to provide some information to all of the providers on the rules and requirements related to the needs assessment and individual service planning and social history. And Cheryl will offer best practices for completing these on behalf of your clients. Some housekeeping pieces. We have an opportunity for you to send in questions. When questions arise, just use the questions function on the webinar interface in front of you, and those will be reviewed by us here, and we'll find time to stop to answer those questions throughout the webinar. We would like to hear from you, so if there are things that come up, please do send in those questions. Other than that, I'm going to turn it over to Jill and Cheryl to get started. So thank you both for being here.
Thank you. Well, this is Jill Slykew from DHS, and as said, I'm the HCBS Unit Manager. And you may be wondering where the Child Care and Adult Day unit is rather than HCBS, but in the last couple months we've been transitioning Adult Day in the licensing division from the Child Care unit into the HCBS unit. There were a number of reasons for this, but we really think it's going to be a nice fit with the HCBS unit. Prior to Adult Day, the HCBS unit was licensing 245D providers, but now we'll be licensing 245D and Adult Day providers. And a number of you hold both of those licenses. So over time, we're going to find ways to sync up your licensing reviews so that we're conducting those licensing reviews in a more coordinated manner than we may have in the past. We're just finding that the people who are receiving services at Adult Day centers are very similar, or maybe people who are also receiving 245D services. So we're really looking forward to getting to know you. So you're going to hear from different names of licensors now at DHS than you have in the past. But again, all the standards have remained the same. So there's no changes as far as requirements from the licensing unit. There's no changes in what you need to do. But you'll just be interfacing with a different person, and we're really looking forward to getting to know you. Introduce yourself, and I'll let Cheryl introduce herself.
I'm Cheryl Shanks, Camellia Club Adult Day Program Director. I brought along a few best practices this afternoon for when you start a new client in your day program. So,
moving on, huh?
Yep.
Okay, so first we're going to talk about the needs assessment. And all these requirements that we're talking today are found in Rule 223 or 9555 point something. So this is in 9700 subpart 2. And first of all, for a needs assessment, the first thing that we're going to look at is that the rule says it must be conducted immediately upon admission. And that immediately means within the first 30 days that it needs to be developed. And it needs to be developed in order for that preliminary service plan to be completed also within 30 days. There will be a piece that the needs assessment must be based on an observation of the person. So we would expect you not to conduct the needs assessment within the first hour that the person walks in the program and as they're sitting in maybe a director's office. So it's based on the observation of the person over time. And then it's also based on information obtained from other sources. So we want you to be watching and looking and seeing how the person is doing, but we also want you to be going out to other sources to see if these things link up or if they may have some other information that you're not going to be able to readily obtain through observation. So 3 areas that the needs assessment must address. First of all, it's the psychosocial status. So you're looking at the awareness level, their personal care needs, and their need for privacy or socialization. So some individuals will present as needing more privacy, while others have a need for more socialization. The second area is their functional status. So you're looking at endurance and their capability for ambulation, how they transfer, and how they're managing their activities of daily living. And then the third area is physical status. And again, this is determined by observation, the intake, screening, interview, and you're looking at any medical reports also. So Cheryl, I think you have some best practices that you want to talk about within the context of needs assessment.
Yeah, so when the client comes in, you meet them at the door and you're right away you're in an assessment mode. Then you sit down with them and you ask them, do they wear glasses? If they don't have them on, can they hear by themselves or with assistive devices? And do they transfer by themselves? Do they use products in the restroom? There's a lot of key parts to the needs assessment. Their awareness levels. Do they have a history of mental illness? Do they have a dementia diagnosis? Do they ever have depression? Their behaviors. Are they physically or verbally aggressive or self-abusive or easily agitated with noise? Because with a day program, noise is part of the day. We use music and it can be quite disruptive to someone that's hypersensitive to that. Part of the needs assessment is with their diets. Are they on a regular diet, a no concentrated sweet, no added salt, any kind of thickened liquids that they would have to have. And then my question to them too is, were they social before they retired?
Mm-hmm.
Did they belong to groups? Did they volunteer? How many days a week is part of how much they're going to be coming to. Is it going to wear them out? I caution families and caregivers that their first day they may come home exhausted or come home and say they didn't do a thing. So there's just a lot of pieces with the need assessment. Another piece of it is medications. Do they take their medications themselves? Will we need to remind them or dispense? Do they have to eat before or after their medications? Another part of it is, can they manage their own money? So because we go on outings into the community, will we need to help them and assist them with their finances? Bathroom help, dressing help, getting on and off the bus. Will they isolate themselves is a big thing too. And then I know she mentioned exercise. Right on the history and physical that comes from the physician, we put on there, can they participate in a structured exercise program? And so you'll want, I also do what I call a pre-admission part of this, and this is how will they adjust to this day program? Um, so I guess that's...
So, and I can hear that there are so many things that you're looking at in this needs assessment time that, again, somebody may answer these questions in one manner, but then again, I think that's the reason for the 30 days, is to make sure that how they're answering you is also what you're observing and seeing, or that others are seeing, or that maybe, again, as we were talking about, somebody who maybe has been isolated and has not had a lot of stimulation, even in that first 30 days, we may see a difference from day 1 to day 30 about how they're engaging with others, because the stimulation that's provided at the adult day may really assist in then your needs assessment of that person.
Right. Right. And when doing your needs assessment too, I always think it's really important to have the prospective client try and answer these questions. Most families, when they bring them to the day program, and not all, but most, are pretty burnt out by the time they're coming. So they're not maybe answering honestly or what they're seeing at home. And so that's...
And I also think, from my own personal experience, sometimes people think that you want an answer, and they may be answering you in a way that they think you want them to answer.
Right.
And again, maybe over time, as you've developed some rapport and a relationship with the person in this first 30 days, you might want to come back and ask those same kinds of questions, because again, a different relationship's been developed, and they may answer it differently, and they may understand it better also. It's a lot of information for people to take in, and just that question and answer time, I think, can really wear people out.
Yes.
And I know, again, speaking from experience with a family member who just wants to be positive and agreeable, the answers tended to be always in a positive framework, and not, and again, like, just maybe not the answer. They thought they were giving the answer you wanted versus the reality of the situation.
If I could, can I interrupt with a question really quick? When providers are completing the needs assessment and going through all of those questions that you had just mentioned, Jill, is there a certain format that you would want them to follow for record keeping that would be best?
There isn't.
Okay.
We don't at this time have any specific, and we're not ever going to have a specific form that you must use. If statute or rule demands a form to be used, it'll be spelled out specifically like this. So every program can develop their own forms. These are minimum standards that are on the presentation, and Cheryl's here to talk about some best practices, which again tend to be more standards, or I mean beyond the standards. So she's giving you lots of good examples of other things that can be on your own form, simply because you've found over time these are things we need to know. We're only going to license and monitor you for those minimum standards. So what we're going to look for for the needs assessment, because it needs to be done in 30 days, we're going to need to know when services started, and we're going to need when the needs assessment was completed. So we're going to need to see some dates about initiation of services and a completion date on that needs assessment. We're not going to expect that it's done in one day or in one session, but we will need to see that it was done within 30 days.
I also offer a trial day for my folks, just to see if we can meet their needs, which is, it's helpful because, like you said, you want all this paperwork within 30 days. And if they come and we already done all this paperwork and they come once, it's quite,
Sure.
But so we do an intake form, a new client form we call it, and then of course it has their diet and how they ambulate, and if they're riding the bus and all that. But that's helpful too, to do that trial day without doing all the paperwork.
Yes, and if we are doing a licensing review and we just want you to be very clear about who is a participant in your program,
Mm-hmm.
and if there are those people who are there who are observing or even participating to some degree, maybe they are having a meal at your program
Mm-hmm.
in order to engage in that aspect of the program and to understand it better, that's fine. But we would expect the license holder to clearly identify who's who and why they're there.
You're right.
So we really want to know who the participants are, and if there are visitors,
Mm-hmm.
we would want to understand their context of why they're there.
And I clearly marked that on my attendance.
Yeah.
I have a whole different page that it's trial day. And so it's pretty spelled out, and wrote a few other places too. So,
Great.
okay. Ready?
I'm ready. So
Okay.
we'll move on to the preliminary service planning. So we have these two interesting deadlines. Both the needs assessment and the preliminary service plan need to be developed within 30 days of admission. So they have the same timeline, but you understand that the preliminary service plan is based on the needs assessment. So clearly in the way that it's spelled out, you need to complete the needs assessment prior to the preliminary service plan. You have 30 days to develop the preliminary service plan, not 31. So you're going to have that needs assessment done prior. It's coordinated with any other plans that this person may have. And as we were talking about, what would those plans be? If you're serving people on our disability waivers, DD, CADI, or brain injury, those individuals should have a coordinated service, CSSP, coordinated service and support plan. Individuals on the elderly waiver should also have a plan from their care coordinator. So that would be one plan that we would be looking at, that you are coordinating your preliminary service plan with any other plans that the person might have. And especially if those case manager or care coordinator plans specify something that you will do in the adult day program, then we're going to be lining up your service plan with the CSSP or care plan and seeing if they match. So you can always provide more services than are specified in this plan, but if the CSSP or other plans from the case managers or care coordinators, we're going to look to make sure that you're doing those things if they've specified that they want you to do something and be responsible for that.
Mm-hmm.
Can I ask a question again?
Yes.
For those CSSP and plans for people on elderly waiver, if it doesn't call out adult day providers in a specific way, what sort of coordination would you be looking for that component?
Yep. So if the plan is written but it's not specified who is doing something, what we'd recommend you do is reach out to the case manager or care coordinator by phone or email and just ask for some more specificity, and then have that documented in the person's file. So if it said something about maybe some dietary issue, but it's not clear what your role is in that,
Mm-hmm.
then just talk to them. Email's nice because you get it all documented, and then it's part of the plan.
Mm-hmm.
Or in other ways, we've suggested sometimes sending an email to that person and saying, the plan says that we will do, well, give me an example, something that we would take them on hot air balloon rides 3 times a year. And you're just going to say, you know what, we're not going to do that, and I just want to clarify that that's not an activity we provide here, and so we can't meet that part of the plan. And unless I hear from you, we'll just assume that you and the other members of the team agree with this decision. Because sometimes it is, again, it's that coordination of the communication can be difficult. So if you just want to specify, the plan says this, but I'm alerting you that we're not capable of delivering that. A lot of times what we'll see is something about staff training. And maybe they were talking about staff training at the group home that a person is living at, and they weren't thinking about adult day. And so you just want to specify, while the plan says that all staff will have training in X, I want to clarify all our staff will not have that training.
So we've gotten a couple of questions on this topic. The first one is, do we need to scan the CSSP into our adult day record?
Yes, it should be part of your record.
Okay. The other is a comment indicating that providers rarely receive the case manager care plans.
Mm-hmm.
The health plans don't furnish those. So what would you suggest in that situation?
I would suggest you request them, but we can't hold you, and we will not hold you responsible for someone else's responsibility. So you can't be faulted, Cheryl, if you've requested a plan and it's not been provided to you.
But you need to document
that
it's not provided upon request.
I think that's a best practice, to document that you've requested it and that you haven't received it.
Okay.
Yeah.
Any other questions on this piece right now? Feel free to just use the questions function on the webinar interface, and we will get them.
Yeah. Going on, so here are some of the things here are the things that must be in a service plan. So again, we're talking about those minimum requirements in a preliminary service plan. Cheryl's going to talk about other additional things that she would put in a service plan to better serve people. So we need the scheduled days of attendance. How many days and what days is a person attending? That the transportation arrangements need to be determined at this time. Who is bringing them to and from the program? That nutrition needs need to be included, with any dietary restrictions, if there are any. That the role of the caregiver or caregivers is delineated in how that's going to carry out the service plan. And that the services and activities in which the person will take part in immediately. So this again is being written at a 30-day piece. So maybe they're still exploring what services and activities they're very interested in. And this is why we're calling it a preliminary service plan. This is going to change over time. But at this kind of 30-day mark, we want people to be identifying activities in which they're going to engage in at this time. So things may change, but we want services and activities to be identified at this time. And we've had some interesting conversations about persons who say, well, I'm opting out of all activities that are being offered. And the conversation has gone to the point that if a person is not interested in participating in the services and activities at the program, then they're really not interested in the program itself. And while we will hold you to be responsive to people saying, well, I'm really interested in X, Y, and Z, and that we would hope that you would be able to accommodate people who come to your program with maybe new or different types of activities that they have interest in. If they continue to just not want to engage in anything, then that's really a conversation then for the adult days. May not be the service the person wants or is meeting the needs that the person and their caregivers really thought it would meet.
Oh, you know what? We've gotten a few questions.
Okay.
That's okay. A couple relating back to those care plans in DHS, wanting to know why DHS doesn't require the health plans to send the care plans to providers.
I'm gonna, beg your forgiveness that I'm coming from the licensing division and not the policy division.
Okay.
But I'm gonna take that note back, because this is not the first time that we've heard this. And so I don't know where that kind of piece hits, but I think the feedback that you're not getting those even when requesting, is information that I will take back to the aging division.
Okay, great.
Aging and adult services really, I think, is probably where we're seeing more of that issue is folks on elderly waiver.
As opposed to-
So, yeah, as opposed to the disability waivers.
Right.
Okay, so I'll bring that back to the policy division, maybe in a couple weeks when we have our other webinar. I can give you a little update about what the response was with that.
Okay.
But again, from a licensing standpoint, my message is I don't want to hold Cheryl responsible for something she has no control over.
Okay. Another question is, what would an answer look like for the role of the caregiver in carrying out the service plan? When you complete that part of the plan, what's a...
So the role of this, if they live with their caregiver or they live independently, if their caregiver is transporting them, we need to know who is transporting. Of course, that's part of the HIPAA, another whole ball of wax. But if they're providing their medications and making sure that we have their medications, making sure they're up and ready for the bus in the morning is another example of, do they want to hear from us, every month? Do they want to hear from us at their quarterly reviews, how they want to hear from us? Do they want a phone call right away? Just over the last year, I have a lot better success with emails. So you get instant response with an email to if there's something going wrong or if there's something we need for their. So that's kind of the role of the caregiver. If they've locked their key in their house and we can't get them home, what they want us to do at that. So that's kind of the role of the caregiver.
I think we've seen sometimes where on either side, from the caregiver or the adult day provider, maybe if a certain behavior or something is, like if a fall occurs, that both sides would want to notify the other side. So that could be the role of the caregiver is, I will notify you of any falls that the person's experienced. So that's going to inform you about their care for the following day or days, because maybe they shouldn't be participating in an activity, or that you want, or it just heightens an awareness that maybe something else is going on. So I'm trying to, again, some other people who have certain diagnoses that you might want to have that role of the caregiver is, again, informing you about something. And it's a two-way street, right, Cheryl? That you're also informing them of things you see.
Yeah.
And sometimes we've seen the caregiver retains responsibility for a meal, that's a choice that somebody's making, and so that they retain that role too.
One final question about providers are asking if they should ask to participate in the care plan meetings, since if they are not getting a copy of the care plan afterwards. So I don't know if that's something that you've done in the past, Cheryl, ask to participate in those care plan meetings with the case manager.
Yes,
okay.
Yes. I do. They're usually held at their place where they live, and you go right to their home and participate in their care plan that way. It's called quarterly reviews for them, or annuals, or So, and that's helpful because then you, I hate to say it like this, but you get into their home and you kind of see what their home like is like. So that's helpful in the adult day too.
Yeah. So I think definitely as a license holder, you're considered a part of that person's interdisciplinary team, and so being engaged in planning meetings is always appropriate.
And then the vendor reports too. that's every 60 days you send out a vendor report to the case managers, and they'll look at that and maybe have questions, and that will open up the conversation with those case managers.
And I think Cheryl, you had some other preliminary service plan best practices we were talking about before we started the webinar. I think you were talking about SOAP notes and how you use those at this point.
On the first day, or initial, I call it an initial plan, I do a SOAP note right in their chart, and that tells pretty much the same things, only it's condensed into how many days they're coming, if they're using our bus, their diagnosis, everything that you do in a needs assessment, but it's right there in their chart, right up front. So if your staff is asking, do they go to the bathroom by themselves, they can go in there and look at all one place, because a care plan, as you're kind of seeing, is 4 or 5 different pieces. So with an initial note as a SOAP note, all the information that you know that you've gathered at that pre-screen is on that SOAP note. So that's helpful to.
Great. We did get a number of questions on what is a vendor report.
Oh, a vendor report is, I don't have one with me, but it tells what activities they participated in throughout the month. So if they've gone on 2 outings, or they participated in an art class, they participated in the church service. Then on the reverse side of that is they want to know the weight, their blood pressure, if they've been coming on the days that they're supposed to be coming, how many days they've missed. What else
Is that a practice you've put in place?
No.
Or is that something that care coordinators have asked you to send them? We're saying, oh, well, it could be both, right?
Well, it can be both, because if you get your referral from the case manager, you can ask at that time if they want the vendor report and how they want it. So you either email or mail it or fax. But those are the kind of vendor reports that they want every 60 days. And I guess that goes back a long time ago. I kind of I didn't really expect to talk about that, but it kind of came up. So, yeah, so it kind of gives them a idea of if their money's going to the best possible care that their person can receive too.
Do we have other questions, Roni?
Just one other question about, I think you answered this, but it's the case manager asking for the vendor report?
Yes.
Okay.
Yep, you ask at your referral if they want a vendor report.
Okay.
Okay, and then finally we're going to talk about individual plans of care. And these are developed within 90 days of admission. So we've had now 3 months of learning about a person, and we're going to develop this individual plan of care. And it's developed by your center staff, but the emphasis would be together with the person, any caregivers, and any other agencies and service providers. And I know that many of you on this webinar have heard the department and the move towards person-centered principles. Well, Rule 223 was written a long time ago, but in the same context, I see this as very person-centered when you're developing these individual plans of care. And so this is really something to emphasize. With all our services, we do want them person-centered, and this rule does support that, because we want these individual plans of care to be developed with that person and those other people that know that person best. And then minimally, again, this plan of care must be dated. And here's what it needs to include. It's an update to your preliminary service plan. So you don't need to throw that preliminary service plan out the window and start over. You can update this to create the individual plan of care. You're going to include any additional services required by the person, but maybe not identified initially. So they came to your program, and now we've determined over these first 3 months that there's some other services the person may require. We're going to look for short-term and long-term objectives. And in the rule, it talks that these objectives are concrete, they're measurable, and they're time-specific. So we don't want objectives that talk about what staff will do. We want objectives about how the person, objectives that the person will be learning. We want to know who the staff are that are responsible for implementing the plan and the anticipated duration of the plan. And then finally, we're looking for quarterly reviews and quarterly revisions as needed for the plan. Licensors wanted some emphasis on the quarterly review and quarterly revisions, because what we want to see is that you're really looking back again at those short and long-term objectives. And if you're seeing growth or maintenance for that person, then that's a good place to be. But if we're not seeing that the person is retaining or learning new things, then we want you to make revisions to the plan rather than saying continue on and continue on every quarter with no change. And also, again, we're looking at that as you're doing these quarterly reviews and revisions, if the person's interests have changed over time, that their objectives are also going to change. Maybe they were very interested in a specific program that you offer, but their interest has waned over time. So we would like to see that, again, that these objectives are reviewed and that they are revised as needed. So there's not a specific piece that demands that there's quarterly revisions, but we will be asking questions about why a plan hasn't changed if a person doesn't at least maintain their skills, and we'd hope for some, at least maybe some growth in some other areas, depending on the diagnosis of a person. We understand that sometimes with specific diagnoses, we're not going to see growth, but we'd hope to see maintenance, or we'd hope that the decline is not as fast as anticipated at admission. So I hope everybody kind of understands what we're looking for there. But again, for best practice, Cheryl, we probably want to see something more than continue. There'd be some rationale behind the continuation of an objective, and some decision making over time. So I'll move this here.
Okay, so I guess with an example would be the client comes in and we put them on a bathroom regime, which is taking them into the bathroom every 2 hours, and we're finding that they're wet.
Mm-hmm.
So we would put them to a 1 hour. And so that at that 1 month or 90 day or whatever review, because we do, review if they're participating in going on an outing and they had a really rough time. We would want to address that right away. Maybe have them switch days that week. So because sometimes that social part of it is tough for them. So that would be something that we could measure. What else could we measure? The music, like I said, we use music a lot. And at first they may love the bands or the musician that we have. And later on, then it's just too much for them. So we would offer them a different activity and in a quieter place. So those are all kind of your individual plans of care. The exercise, at the beginning, they don't want to do it at all. But when they see everyone else doing it, that's a measurable, then they start participating.
Yes, so I think again, that's that exposure. So there's a reason for that preliminary versus the individual plan of care, because I think at 30 days, it's still, people are pretty new to the program. They may still be reluctant to participate, or they may have felt that they had to participate in something that they now at 90 days would be saying, this is really not what I'm interested in.
Right.
And I understand you have something else that really is something that I'm much more interested in.
Well, too, if they only come one time a week, at 30 days, you've only seen them 4 times. Where at 90, then you've seen them 12, and you get a better feel for what they like to do.
Do we have some questions?
Not quite yet. I have a question on just some examples of some short and long-term objectives that would be included in an individual plan of care, things that either of you have, Jill, that you've seen, or Cheryl, that you've written. Like, what would be an example of a short-term objective and a long-term objective?
Maybe walking. Or they're in a wheelchair and we've gotten them up to exercise and they progress to a walker.
Okay.
Or come with a walker, progress to a cane, or independent.
Yeah, and I think, so with that example, those would be the short-term objectives, and the long-term objective would be to maintain their mobility as independently as possible, or to maintain the mobility through the use of some kind of assistance, but they're still able to ambulate independently with the aid of the walker or the cane versus the aid of a person or a wheelchair. So the long-term objective is mobility and their ability to, you might measure that with no falls, that we're, our long-term objective is to not have falls. And so our short-term objective is to work on balance in the structured daily exercise, that we work on balance, because our long-term objective is this person's not going to fall. So, and then when I was talking about so the difference between a person goal and a staff goal. So a staff goal is staff will have an exercise class 3 times a week. Well, we want to make sure that the person's participating in the exercise class. So it's not that what staff are doing, it's that the person's participating. A goal that staff will dispense medications is not a goal for the person. But if we want them to be able to maybe work with staff about articulating what meds they're taking and why, so that then again they would be independent in taking their medications at home.
Great. And then regarding the duration of the plan, that's for each one of these individual goals, or just the plan in general?
Each plan, isn't it? Each
Each
goal is
we would look
different.
I believe it's the duration of each objective.
Okay.
And again, working with Adult Day, as I started out talking about when we work with persons under the 245D waiver, we have a variety of people on that service plan, or that under that licensing rule, and it includes people who are learning new skills. And people in Adult Day, we're very clear that there are some individuals where losing skills is expected. And so it's not, again, you can be doing best practice and you can be doing everything you can, but a person, because of age, because of a diagnosis, may over time lose skills, and that's not going to be reflected that the license holder's not doing their work. Rather, what we're hoping is with the services that you're providing, that maybe those skills they don't lose their skills as quickly, and that there's just safety in the provision of the service. So as they lose these skills, the service that you offer as an adult day provider is supplementing and protecting them from the vulnerabilities that their age or their diagnosis may present. So it's a different group of individuals than we see maybe in some of the other services that we license.
Yeah.
And there's really definitely a recognition that it's not always appropriate to be talking about growth and rehabilitation or habilitation, but maintenance or allowing that decline hopefully not to be as rapid or as significant.
Yeah.
Yep.
Okay, any other questions?
Cheryl, I think you also wanted to talk about really right up front, and something that didn't get put on the slides was talking about their ability for self-preservation.
Yeah, so when you do their initial the assessment of their vulnerability, can they ambulate? So this is all what determines if they're capable of self-preservation, and I think that's a rule.
That is part of the rule. We didn't
Yeah.
put it in the slides, and if people have more questions about it, we could add that to next time
Yeah.
if people want to hear more about that too.
With the determination of self-preservation, you could tell when they come in if they're ambulatory or mobile, and would they recognize the danger signal or an alarm requiring evacuation? Would they initiate and complete the evacuation? Would they select an alternative means of escape if the main exit was blocked? And would they stay outside in a location where they're told to stay with a group? And any of these questions that they answer no to would make them not capable of self-preservation. And that, again, goes along with your staffing ratios of 5-to-1 or 7-to-1. Yeah.
And I think you were saying you use that as part of your determining and developing the needs assessment.
Right.
That's
Right.
kind of one of the key pieces that you look at the very beginning.
Yeah. It is. It's right in the first section that you.
Yeah. And we'll plan
And that changes too. They may come in totally capable of self-preservation, and that changes.
Yeah.
So you are reviewing that too at your 30 days and then quarterly as well.
Yeah. Okay. Well, I haven't gotten any other questions. Do you have anything else that you wanted to add on this topic specifically for these three areas?
No, I think
Okay.
that, again, appreciate this opportunity to talk to you. At the end of this presentation, so contact information, I do want to talk about, in the HCBS unit, we have a phone number that is staffed by a licenser during normal business hours. So you can always call us at 651-431-6624, and you can ask any question to do with your licensing standards. Also, we do have the piece of the DHS website that belongs to licensing. So if you go to the main, we're lucky because the DHS website's kind of complicated at times, but you can find licensing pretty easy. If you go to our main page, which is mn.gov/DHS, under general public, the licensing is brought down and you can link to there. And in that way, you can get to us too.
And your website or that email link that we're all connected through with Leading Age, that's helpful for all the providers, I think, to
To send
bounce
this. Yep.
questions off each other. And
Yeah, on our Adult Day listserv.
yeah.
Yeah. All right, well, we haven't gotten any other questions, so I think we're going to end today's webinar. And keep in mind that we have another one scheduled for August 9th at 3:30, and that one will focus on the Individual Abuse Prevention Plan and the Program Abuse Prevention Plan. We can also add some information and go a little bit deeper into the determining the self-preservation status in that session as well. So feel free to register for that. And I just want to say a big thank you to Cheryl and Jill for taking the time to share your expertise with us. We really appreciate it. And for everyone who took the time to be on the call. There were some questions about if this is being recorded. It is indeed recorded, and it will be up on our website hopefully soon through the magic of getting everything up on the website. So thank you, and yeah, thank you. Goodbye.
Thank you.
Bye now.